it's really nice to have an opportunity to connect with and engage with people from around the world, even if it's just through Zoom, and makes us feel a little bit less isolated. So the title of my talk, and Loren and I will be covering a talk focused on cognition-oriented treatments for people with dementia. And you can see here my affiliations and sources of support. I have nothing to disclose. And cognition-oriented treatments are part of a broad class of treatments referred to as non-pharmacological treatments, and I'll be focusing just on those sort of group of treatments that we refer to as cognition-oriented. And what I'm going to do in my time is just touch on some basic concepts and definitions, describe these types of approaches to you a little bit, and some of the evidence behind them. And Loren will follow up after me, describing a little bit more practical aspects of their implementation in clinical settings. And we are both here to then try and answer as best as we can your questions. I know that we have in the audience a mix of people, people living with dementia, potentially some of their partners, healthcare professionals and researchers. So we've deliberately kept the talk reasonably broad, hopefully not too technical, but as I said, we're very happy to answer your questions afterwards. And Kate has already mentioned that Loren and I, along with our colleagues Nicola Laudenschlager and Kate Fox, contributed a chapter to the Dementia Rehabilitation book last year, which is focused on cognition-oriented treatments. And the talk we're giving today is loosely based on topics covered in this chapter. So just to kind of quickly recap or touch on some basic concepts that are probably well known to most of us here in attendance today. Dementia, or sometimes referred to now as major neurocognitive disorder in the DSM, is not a disease in itself, but rather it's an umbrella term that refers to a clinical syndrome or a group of symptoms that tend to go together. And this syndrome may be caused by numerous different diseases, neurodegenerative diseases, vascular diseases, and others. And the most common of them is probably Alzheimer's disease, but there are many others like dementia with Lewy bodies and frontotemporal dementia, Huntington's disease, and so on. So there are many etiologies or conditions that cause dementia. Dementia itself refers to a clinical syndrome. In terms of the diagnosis of dementia, it is supported by, first and foremost, the presence of a significant decline in one or more areas of cognition. So by cognition, we mean the kind of different types of thinking and cognitive processes that underpin many of our daily activities. And you can see here on the slide a number of kind of typical examples like perception and attention, memory, or reasoning and judgment. These are all kind of the building blocks of our thinking and intellectual skills and underpin most of what we do in our day-to-day life. And at the heart of dementia, there is a decline in one or more of these cognitive skills. So decline means that it also needs to be a change from previous levels of functioning. So it can't just be somebody who's been impaired or had sort of areas of difficulty in some of these cognitive areas for many years. The other sort of main feature of dementia is that these cognitive deficits interfere with one's ability to carry out activities of daily living independently. So both very complex activities like planning a trip or navigating in a complex environment, as well as more basic daily activities like dressing and showering and undertaking relatively simple everyday tasks. All of these are underpinned by thinking and cognitive skills, and this needs to be interfered in order for a person to be considered to have met criteria for dementia. And finally, it's very important that these symptoms are not better explained by the presence of another condition, such as delirium or depression or any other medical condition that could give rise to these symptoms, and therefore dementia is by definition a diagnosis of exclusion. Now, as you're probably also well aware, dementia due to neurodegenerative diseases such as Alzheimer's, as well as due to vascular diseases, is typically thought of as existing on a continuum from mild through to moderate and then severe stages, where in the milder stages of dementia, the symptoms can be a little bit more difficult to distinguish from what is sometimes seen in the context of healthy aging or regular aging, and functional independence is typically reasonably well maintained. So it can be a little bit more difficult to diagnose clinical dementia in the very early stages, but as it progresses into the moderate stages and more a wider range of everyday activities is affected, then it is easier to diagnose and also more difficult to distinguish the underlying disease. So we've learned a lot over the last 20 or so years about the various etiologies or diseases that cause dementia and how they are different from one another in the early stages from a cognitive, behavioral, and psychological perspective. One thing I'd like to quickly add on this one is that sometimes we hear people talking about having early onset dementia, and what I think happens sometimes is that we see some confusion between the reference to the stage of dementia in terms of severity, between mild, moderate, and severe, and between the age of onset. So we use terms like younger onset dementia and later onset dementia, really to refer to this relatively arbitrary age cutoff of around 65 that distinguishes between people who have an onset of dementia relatively younger and those that have an onset of dementia a little bit older. So important to note that early onset disease really refers to the age as opposed to the severity of the condition. The World Health Organization provides us with a framework to understand the impact of disease or injury as one that it occurs at 3 levels. They are the kind of level of body function and structure, at the level of activity, and at the level of participation in everyday roles and activities. And these are also impacted by contextual factors, both in the individual as well as their environment. And in the context of dementia, we may think of the cognitive deficits, the kind of core impairments in things like memory and attention and reasoning and so on, as representing the impaired bodily functions or structures. The activity limitation is the level where a person, because of these symptoms, might have difficulty engaging in some activities. For example, a person might have difficulty learning or recalling the names of members of an exercise group, and that's an activity limitation. And at the level of participation, this, for example, using this example, might mean that a person might avoid attending an exercise group and therefore is restricted in their participation in a role that is meaningful to them. So you can see that the impact of dementia can be described at those 3 levels, and this also is a useful way of thinking about what we target in our interventions and treatments. And when we think about prevention, it's again common to hear about those kind of levels of prevention. We talk about primary, secondary, and tertiary levels of prevention, with primary prevention typically referring to a state where what we're trying to address is risk factors for a disease, and the person is free of disease or illness at that point. At the level of secondary prevention, we are really focusing on also both early detection, but also minimizing the impact of disease and its further progression. And finally, at the level of tertiary prevention, the focus is more on treatment and care to manage as best as possible the condition and optimize quality of life. And in the context of dementia, these levels of prevention are related to things like age, advanced age, and then reductions in cognitive function and increase in pathology, with primary prevention typically referring to those who are considered cognitively healthy and typically a bit younger. Secondary prevention, referring to people who might in some cases have preclinical disease or some mild symptoms, but are typically still quite independent. And then in tertiary prevention, we are talking about either people with manifest Alzheimer's disease or mild cognitive impairment due to Alzheimer's disease. And the focus here is on optimizing quality of life and maximizing independence and prevention of further disability. In Australia, the guidelines for management of dementia for GPs include a range of recommendations in the context of dementia prevention, and one of them is increasing participation in social and cognitively engaging activities. I suppose Loren and I, being neuropsychologists, have a natural interest in those kind of cognitively engaging activities and in cognition in general, and how to engage in those in the most meaningful way. And this is relevant across the continuum of prevention. But there's a lot of interest in cognitive activities and in cognitively engaging activities, but there's also a lot of confusion out there about what it really means. I mean, people engage in a wide range of cognitively engaging activities, both spontaneously or as part of a structured program. And we are here to sort of try and help make a little bit of sense of the different ways that we can approach this. In the aging and dementia research environment, we've sort of focused in the past 20 years or so on these broad three broad classification classes, if you like, of cognitively engaging activities. They are referred to as cognitive stimulation, cognitive training, and cognitive rehabilitation. These definitions were sort of provided by my colleague and mentor, Linda Clare and Bob Woods from the UK. And they've been very useful and used by the research community and the clinical community for the last 20 years. They're not perfect, and there's a lot of problems with the classification and distinguishing the kind of finer aspects of these approaches. But as I'll hopefully be able to illustrate and demonstrate now, there are quite important differences between them, and they are useful in different ways. So just focusing or illustrating the first of these approaches, cognitive training, let's look at an example of a typical activity that a person might be undertaking when they do cognitive training. Here, taking a task on the computer, they might be facing a scene like this, where there's a number of objects, in this case water lilies, on the screen that lit up in a particular sequence, the first, the second, and the third. The person needs to pay careful attention. This task, by the way, is about training what we call visual attention and working memory. And then when the computer finishes presenting the order in which the lilies lit up, it's the turn of the participant, and they need to click on those flowers in the same order that they've seen them lit up. So they need to really remember the order, and this gets more difficult as the person improves in their performance. So there are going to be more lilies to remember, a longer sequence to remember, and this trains visual attention. Here's another example. Imagine that you're looking at an object like this, a kiwi fruit, and then all of a sudden this puzzle gets scrambled, and your goal is to try and remember how to reassemble this puzzle into its original form with as fewer steps as possible. So again, here you're exercising something called visual construction, as well as reasoning and working memory. So many of these tasks tap into several thinking skills in a more or less structured way. So in short, cognitive training is something that involves the ongoing repeated practice on tasks like the ones that I've just shown you. They are standard tasks. They are quite well structured. Sometimes they look like games, but they really are supposed to measure relatively specific skills like reasoning, attention, memory, judgment, and so on. Some of those cognitive abilities that I've shown you before. And the level of difficulty of these tasks can be manipulated such that if you're doing really well, the task will become more difficult. But if you're not doing so well, the task will become less difficult. So the idea is that people always practice at a level that challenges them enough, but not too much. So this is at the heart of cognitive training, is treating a little bit the brain and our thinking skills like a muscle that can be strengthened, that can be improved. And the assumption and hope is that by training a particular ability, such as memory or attention, using a task, what we really improve is not just that the performance on the water lilies, for example, but on other tasks that involve visual attention and working memory. So remember that we are training people with a computer task potentially, but the goal is not just to improve them on that task, but we hope that through strengthening of those basic underlying abilities, this would mean that people can perform better on tasks beyond that. Now, there are a lot of companies out there that are part of a very, very lucrative sort of so-called brain training, cognitive training industry. And I'm not here to, these are just a small example of some of the companies that you might come across if you were to sort of Google cognitive or brain training. I'm not here to endorse any of these companies, but I will say that there's research. Some of them have been better backed up by research evidence than others. And many of them have in the past, I suppose, made some exaggerated claims around their efficacy, but I think in the last few years we're seeing some toning down of kind of claims about efficacy. Certainly no evidence whatsoever that these themselves can prevent dementia. There's an excellent review from colleagues here in Australia, in Western Australia, from a few years ago that provides evidence specifically in relation to these commercial companies. You're very welcome to take a look if you want and look at the evidence behind them. Now, I showed you this wide range of activities that we engage in daily life. You know, it can range from reading books and magazines and visiting museums, playing chess, playing the drums, or even listening to me. And these are all considered cognitively stimulating activities. So when we talk about cognitive stimulation, it's really all of those. But there is also a relatively structured cognitive stimulation therapy program, which was developed by Professor Amy Spector and Bob Woods and some of their colleagues at University College London in the UK. This is a highly structured therapy program and has its tradition in something we call reality orientation therapy. And this approach involves people coming together, usually in a group, but it can also be done individually. It has tended to be delivered with people who might have sort of more moderate and even severe dementia. More common than not, it's been done in kind of residential care facilities, but it can be done also individually at home and with people with the milder stages of dementia. This approach emphasizes general cognitive stimulation with activities that are fun and pleasant, with the goal of improving overall well-being. So the essence of this approach is not so much to improve specific cognitive abilities, but more to improve general well-being. And in the context of this structured session, it's done through 14 sessions, which are called the initial sessions, and these are then followed by some maintenance sessions. You're very welcome to take a look online at the website of the International Cognitive Stimulation Therapy Group. There are a number of manuals that can be purchased and downloaded. They include Making a Difference 1, which is for initial cognitive stimulation therapy, Making a Difference 2, which is for maintenance stimulation, and Making a Difference 3, which is really for care partners, and they can download this as a resource to deliver cognitive stimulation at home individually to their partner with dementia. The authors of this approach, Amy Spector and her group, describe a range of principles that underpin the application of cognitive stimulation and therapy. They include stimulation of language and executive function and implicit learning. They include the focus on ideas, generation of ideas and opinions rather than facts. They focus on gentle orientation, so helping people with dementia with provision of orientation information. They focus on reminiscence on reminiscence on past activities, on gentle movement. I'm just wondering if there's somebody who might not be on mute and could potentially mute themselves. I'm hearing a little bit of noise. Thank you. The provision of memory cues, consistent approach. It's very person-centered. It's really grounded in respect, and as I said before, it's also about being fun. So these are some of the principles of cognitive stimulation therapy that the authors believe are fundamental to the approach. And here's really a description of what the 14-session program looks like. You can see that it covers a very wide range of topics, from sounds to foods to current affairs, word associations, and so on and so forth. So there's lots of very interesting topics that are covered. It's very stimulating, and typically a session focuses on a bit of introduction, a couple of kind of main activities for the session, and some summary and some homework as well. So highly structured approach. Finally, when it comes to cognitive rehabilitation, this really is an approach which is more aligned with the principles of general rehabilitation and the context of dementia. Professor Linda Clare in the UK really adapted what has been already a common approach in the treatment of people, younger people with acquired brain injuries due to car accidents and so on, and adapted it for using with older people with dementia. The main goal and focus of this approach is to reduce what we sometimes call excess disability. So this is a disability that is not required or necessitated by the condition itself. So people with dementia, for example, due to Alzheimer's disease, might have some difficulties that are related to their thinking difficulties, but they might still be able to do many things. And the goal of cognitive rehabilitation is to reduce this excess disability that is caused by other factors like changes in one's mood or lack of environmental supports, changes in one's confidence. And the goal of cognitive rehabilitation is really to maximize a person's capacity to use whatever skills and abilities they still have and the environment around them to allow them to perform meaningful activities. So using the WHO framework that I mentioned before, this type of intervention really focuses at the level of participation restriction, and therefore focuses on meaningful everyday behaviors, such as, for instance, preparing a meal or planning a trip. Unlike the cognitive training approach that I've shown you before, where the focus was kind of training those basic thinking skills in the hope that this would benefit a wide range of activities, this is not what we assume when we do cognitive rehabilitation. When we do cognitive rehabilitation, we identify some personalized goals. So unlike the other approaches, cognitive rehabilitation is always highly individualized. It's really about the goals that are important for this person and for this person's life and meaning. And therefore, the focus of the work is on those goals as opposed to general stimulation. It involves a very close collaboration between the person with dementia and wherever possible, a care partner or family, and the therapist, who come together not only to identify the most meaningful goals for this person, but also to take a range of activities like a careful problem analysis in order to understand what skills are required in order to perform a certain activity, for example, preparing a complex meal. and also the identification of barriers, both in the environment and in the person, to perform this activity, and their removal as much as possible. And then the work is really about implementing strategies. Some of them are really well-researched strategies to assist people with dementia to better learn, better recall, better organize themselves, as well as some environmental changes to allow the person to meet their goals as well as possible. And we don't assume when we work with people in this way that it's going to lead to improvements beyond the area that we're focusing on. The goals that we set are typically referred to as SMART goals in the sense that they need to be specific and measurable, attainable, relevant, and time limited. And here are some examples of what we call SMART goals. So one person might say, I want to be able to bake a cake once per month, or I want to be able to send text messages to my grandchildren, or I want to take my glasses, wallet, and phone with me whenever I go out. So these are really specific, really well-defined goals, and can be the subject, the focus of work with patients. I use in my clinical practice, as well as in some of my research, the Bangor goal setting interview, which was developed in the UK by Linda Clare, and really provides clinicians a very structured way to identify and articulate these goals with patients. But there are, of course, other useful tools out there to do goal setting. Now you know the main sort of therapeutic approaches, and usually people ask me, does it work? Now, after many years of research by many people, including myself, I think it's fair to say that the answer to this question is yes and no. But that's because framing the question in this way isn't particularly useful. I think what's more useful is to ask more refined questions, such as what works, for whom, for what outcomes, and when. Okay, and answering these types of questions requires a really deep dive into hundreds and hundreds of trials that have been done over the last 20 or 30 years, and almost as many reviews, kind of systematic reviews of the evidence that have been done also over the past 15 years. And this is exactly what my former postdoc, Hannah Malmberg-Gavelin, and myself and some colleagues did last year. We published a huge mega review that examined many of these questions, and the main findings appear here on the right-hand side with this very complicated looking forest plot. So it's probably a little bit too technical, and I'm not going to go into these details, but I will give you some selected findings, I suppose, and more than happy to discuss our findings in greater detail later if you want. We found that cognitive training and stimulation leads to general improvements in cognitive abilities in people with and without dementia. This is not the case for cognitive rehabilitation, but this is also not the goal of cognitive rehabilitation. So cognitive stimulation and cognitive training might lead to some improvements on aspects of cognitive performance in people who are healthy, in people who have mild dementia, even in people who might have moderate dementia, but not always. This is, I guess, the general finding. On the other hand, cognitive rehabilitation improves one's satisfaction with their performance of their everyday goals, and this is evidence that is specifically relevant for people with mild to moderate dementia, and it's very strong evidence based on a relatively small number of excellent studies from Europe and the UK with many people with dementia. Another important take-home message here is I think that the evidence supports the idea that targeting the level of impairment using the WHO classification is probably more useful the earlier a person is in the course of dementia. So when people are relatively mild in their deficits, we can still try and target cognitive abilities in the hope that this would potentially benefit them beyond those narrow tasks. As a person progresses and more areas are impaired in everyday activities, I think many clinicians and researchers agree that the focus is probably should shift towards everyday activities and that level of activity and participation restriction. There are many other findings that are buried in this massive report, but in the interest of time, I'm probably going to leave it there. I'll tell you that in terms of translating all this theoretical knowledge and research findings into practice, these are really the most important goals for us as researchers and as clinicians. And there are many important considerations here at the level of the clinician, the person with dementia, and even the healthcare system. But this is where I'm going to leave it and let Loren, who has a wealth of clinical and research experience, take it from here and hopefully provide some additional information about these issues. I'll finish by thanking you for your attention. I'm sorry, I hope I didn't go too much over time. These are some of the relevant websites that you are very welcome to take a look at of my group. And some relevant resources, and I look forward to hopefully answering some of your questions after Loren's talk. So thank you.
Okay, so welcome everybody. Thank you so much for having us here today. Alex has given you a wonderful grounding in some of the theoretical and the conceptual underpinnings of cognitively oriented treatments, particularly focusing on people living with dementia. And we wanted in this second half of our talk today to give you perhaps a little bit more of an idea of what these techniques and what these approaches actually look like in practice. So I would like to, actually, before I go into it, as Kate did, may I just take a moment to acknowledge the traditional owners of Australia and to recognise their continuing connection to land, water and culture. I'm currently on the land of the Gadigal people of the Eora Nation here in Sydney, and I pay my respect to their elders past, present and emerging, and further acknowledge the traditional owners of the country on which you are on if you're in Australia, and pay respects to their elders past, present and future. Okay, so as I mentioned a moment ago, what I'd like to do in this second half of our presentation is give you all some practical examples of what these techniques look like, and share with you from my experience some anecdotes from various cases that I've worked on, people that I've worked with through my private practice, through my work in developing a memory training group program at the Brain and Mind Centre here in Sydney, and also working on one of our larger trials, the IHARP trial, where we use principles of cognitive intervention as part of a reablement program to assist people living with dementia to live well at home in conjunction with occupational therapists and nurses. So I've had an opportunity to work with a number of people, and I'd like to share some examples from that work with you. And to finish off, we'd also like to share some considerations that we think are particularly important, primarily for clinicians, but perhaps are also relevant for people living with dementia and for their care partners, to think about if you are considering some kind of cognitively focused intervention. Okay, so Alex has shared the sort of construct that we think about in terms of cognitive stimulation, cognitive training, cognitive rehabilitation. And as I said before, I'd like to show you a little bit more about what these techniques look like. So under the banner of cognitively stimulating cognitive stimulation therapy, we have something called reality orientation. This was perhaps developed before and outside of cognitive stimulation therapy, but is often utilized within that approach. And this is the idea that we provide external cues regarding the place, the time, the date, the person themselves that are within clear availability and access to the person with dementia. Now, this can be a passive process where the information is prepared for that person and made available, or it can be an active process whereby the person with dementia is involved in generating and updating that information. The key is that the information, as I said, is available and is repeated at regular intervals. So I've pulled out a few examples for you of how this can look. You can see that some approaches take a more verbal focus, including more words and more language-based information. Others incorporate more visual information. Personally, I like a bit of a mixture so that you're tailoring to different people's strengths and the way that they like to think. We don't want too much clutter, and really importantly, we want this to be placed in a central location where it is available. I've seen some of these reality orientation boards used in residential settings where they are, immediately in between a very busy kiosk or cafe where there are a lot of people coming up to place an order. And then on the other side of it is a TV that's on constantly with, something, the news or a weather channel or something. And it's just too distracting. It loses its impact. So I think placement and the way that they're designed is also really important. Now, Alex also shared some ideas around cognitive stimulation therapy itself. And I'll go into a little bit more detail to show you what that might look like. So particularly the program developed by Spector and Woods involves a number of these components. We can think about multisensory stimulation. So this is where we have a range of props or aids or materials that tap into different senses. So we might have things that tap into sound and smell and vision and taste and touch as well. And Alex mentioned also that the idea here is to focus on generating ideas and opinions. So we might ask some stimulating questions around these things like, how do you think that might sound? Would it be loud or soft? Or do you think you might smell that kind of scent inside the house or outdoors? Or, how do you think that might feel? Would it be a hard touch or a soft touch? Those kinds of questions. We can also think about current affairs, generating opinions about things that are going on in the world, particularly in the immediate area. We can look at word games. We can look at pictures of faces. And here we're not focusing so much on identity, but rather the features. So questions that are stimulating here might be things like, who is younger of these pictures? Or what do these pictures have in common? What kind of features, do they share? We can think about activities that revolve around identifying and using money. So, how do these notes or coins, how are they different from each other? What might be the purpose of that? Those sorts of questions. And as Alex mentioned, the idea here is that the activities are fun and they're engaging and they're often offered in small group formats. Next, often offered as part of a cognitive stimulation approach, but can also be offered separately as a standalone therapy. We have something called Reminiscence Therapy. And this is where we provide opportunities to stimulate discussion about usually distant events in a person's history and experiences. And we bring in tangible props or aids to try and generate some of those memories. Now, we might have themes that we follow, like school days or your wedding day or your work life or things that are more general, like music of the 70s. And as much as possible, we try to personalize the props and also offer an opportunity for multisensory exploration. So not just looking at those things, but where possible, picking them up and touching them. And if they're sort of tools, you can see a picture there of tools that we might use in the kitchen, actually feeling them and manipulating them as well to really generate some of those experiential memories. Just as a little case anecdote here, I worked with a lady called Sally who really wanted to sort of spend more time thinking about her family, but was having a lot of trouble recalling their names and sorting out who was who in her mind. And so for her, we created a reminiscence board that involved pictures of her family, recent and older pictures. And each session we would sort of try to discuss the features of those pictures and, if it was appropriate, the identity of the person as well. And we would choose one or two people to focus on. And that opportunity during the session just to talk about and reminisce and think about experiences that she had had with those people really generated a lot of pleasure for her and was a really nice way to orient her as well. So it's an example of how a personalized reminiscence board can be used. Moving now to some of the approaches used under cognitive training. So recalling, as Alex mentioned, that cognitive stimulation therapy approaches are more non-specific, they're more generalized. They really stimulate cognition more implicitly, whereas under cognitive training approaches, we are now targeting specific cognitive skills and functions. And the techniques here are aiming to either restore functioning in areas that are perhaps not working quite as well, or to compensate for those functions by recruiting other skills or other neural pathways that are working better or more strongly to achieve that same goal. So here we can have a strategy-based approach that I'll take you through first. And then also that computer-based approach that Alex showed you as well. So I'll show you some examples of both here. Now, strategy training can target different cognitive domains. Oftentimes it lends itself very well to focusing on memory, and I've listed here a number of these strategies that are used to target memory. I've just picked one out that we have used in our memory training program at the Brain and Mind Centre, which is semantic association. And I'll just spend a minute explaining to you and demonstrating how this technique works. So semantic association is all about finding common features or relationships between items that we might want to absorb and remember later. And this allows us to really chunk or reduce down the amount of information that we need to process, because those relationships or links between the items will act as retrieval cues, so that we only need to remember those broader relationships, and that will trigger our memory for the underlying items. And by thinking about what links these things together, we are actually processing that information more deeply and more effortfully. So our brain is engaging with those items more readily than if we just sort of look at them or hear them once. And that in itself can be quite mentally stimulating. Now, as an exercise, we've used things like the brain injury workbook, where we present an array of items and we ask people to try and absorb or remember as many of these things as they can. And we give them maybe a minute or so just to view it and try and really lay down that information. And then as a group, we will work together to try and come up with categories that link bits of those information items together. And as you can see, I showed you, I'll go back to it, 12 items here, which in actual fact is probably just beyond most people's working memory capacity of about 5 to 7 bits of information. So already this is quite a tricky task for most people. But when we come to generate these categories or links between those items, we now have only 4 groups to remember. We've got flags, we've got sources of light, we've got meats or proteins, and we've got starches. And so by doing this, we've chunked down, we've reduced the number of items to remember from 12 down to 4. And the overarching categories will act as those cues for us to then pull out the individual items. And most people find that the process of finding these relationships, chunking it down, we've also done something called recoding. We've taken information that we've seen visually and we've created verbal labels for that information. All these things that we're doing allow our brains to process the information more deeply and help us to absorb and remember it better later on. So these strategies of semantic association, chunking, recoding are all examples of things that we might use in a cognitive training approach. And Alex talked about the idea that we always want to focus as clinicians on how these techniques help us in our day-to-day lives. So when we think about this idea of generalization, the most obvious everyday example that we think about would be something like a shopping list. Now, I always advise people that I'm working with to take a physical list with you so that you have it there as a backup strategy. But certainly if you're wanting to try and test your memory a little bit or challenge yourself just that little bit, you could try an activity like this with your shopping list quite readily. Okay, another technique that we might use in a cognitive training approach would be something like mnemonics, which are essentially just memory retrieval aids. And these can be things like acronyms, whether they're well known. So I'm sure we're all familiar with the WHO, which is the World Health Organization, as a well-known example. But they can also be personalized. For example, personal example, somebody close to me living with dementia was having trouble remembering the names of the people in my family. Now, my married name is Diamond, and there are 4 people in my family. And so we devised a mnemonic, which involved an acronym, where we actually pictured a diamond and we placed the initials of each of those 4 people on a point of the diamond. And so that the initials were L, S, J, N. And by doing that, we created a personalized acronym that was also linked with a physical movement and something visual that really helped to lay down that information and then to pull it out to retrieve it later on. So just an example of how we can personalize those things. We also often can think about songs or phrases. So I wonder how many of you could finish this phrase if I start it. 30 days hath September, April, June, and November. And look, that might be a cultural thing. It might be dependent on where you've been educated. But generally speaking, there are these little phrases or songs that help to link information in our mind, help to lay it down. And again, we can create those for things that we might be having difficulty remembering. We also have the 5 W's technique, who, what, when, where, and why. And this is really aimed at providing structure around encoding or retrieving information. So we can work with people on using this structure to pull out the key bits of information that we might want to know from a news story or from a conversation, and to communicate just those key bits to try and make our thinking more efficient and effective. And sometimes we might even want to take away the why. So maybe who, what, when, where is sufficient. So we can adapt these strategies as needed as well. Now, Alex talked about computer-based cognitive training, and he did mention that in general, or more broadly, he mentioned that in general, some of these approaches do tend to be probably more appropriate for people who are at earlier stages of illness. And we also find from my research, and I think Alex's research as well, that computer-based approaches tend to be more helpful in the context of people living with dementia when we have the opportunity to adapt them and to tailor them to that person's needs and to their weaknesses and to their strengths. You can see here, and from what Alex showed you as well, that there is a vast array of programs and software that is available. They all look quite different. Some are more game-like, others really look as though they're exercising the brain, and different people will respond to those features differently. So as a clinician, it's important for us to find what each person responds to and what they're likely to engage with. Some other things to think about in relation to using computer-based approaches. We need to think about how the program was developed. So, you know, was this developed as part of a scientific or a research-based approach, or was it developed more with more commercial intentions in mind? And that will often, what we find, often speak to the evidence base for that program as well. Alex directed you to the article by Tejal Shah from 2017, and I strongly recommend that as well if you're a clinician in particular, in terms of trying to weigh up which of the programs have a stronger evidence base. We also need to think about what the expectations are for these programs. So I think Alex mentioned that in general, there is evidence that they can improve at least global cognition in people living with dementia, but we don't know too much about how well they generalize to day-to-day activities. So it's important to be realistic as to what you're expecting to gain if you're using computer-based cognitive training, and to realize that you may get that level of certainly engagement, stimulation, and general improvement, but it's unlikely that this will lead to functional gains in everyday life. Finally, we need to think about things like the cost and the technical requirements as well of using computer-based cognitive training. So there are things to keep in mind. Now, moving now to cognitive rehabilitation. So just a reminder, here we're focusing not on global, non-specific stimulation and not on specific cognitive domains, but here we are taking an individualized approach. We're identifying personally relevant goals. The clinician is working with the person and ideally with their family or caregivers as well, and focusing on improving their performance in day-to-day life. We're looking at using areas of personal strength and compensating for weaknesses. And here goal setting is absolutely critical. I think it has been illustrated really beautifully by Linda Clare's work in the GREAT trial in the UK. And we're addressing things like safety and independence and engagement in daily activities and quality of life, rather than those specific underlying cognitive skills. Now, the process of cognitive rehabilitation, it's important to mention, can draw on really any of the techniques that I've mentioned so far, and others that I'll show you in a moment as well, as long as they are relevant to that specific goal that we're focusing on. So Alex has already explained that goal setting is hugely important, and that we ideally want goals to be specific, measurable, attainable, relevant, and timely. He also mentioned that there are a number of tools available. For example, the Canadian Occupational Performance Measure, Goal Attainment Scaling. I too use Linda Clare's Bangor Goal Setting Interview. I find it a really helpful and user-friendly structured approach to goal setting and also measuring progress. And so I think that's really key, is that when we're setting goals, we need that process to be collaborative. So we're involving the person living with dementia to identify goals that are relevant for them. It needs to be individualized, and we need to be able to track progress to actually see whether what we're doing is having an impact. Now, some questions that you can ask to try and identify and tease out goals would be things like, what are some things that you would like to be doing, or doing more independently? Or are there tasks or activities that you've previously felt you could do quite well, but perhaps are not doing as well these days, and maybe we need to make some changes? What do you enjoy? What's important to you? Those kinds of questions. So some of the strategies that would be used under a cognitive rehabilitation approach would be things like compensatory aids or tools, or external aids in the world around us that we can draw on to help our memory. I've listed and shown you a few examples here. And I'll give you a couple of examples from people that I've worked with where these things have been helpful. I worked with one gentleman called Wes, who one of the key difficulties for him was that he was having a lot of repetitive questioning. And that was very frustrating for him because he felt that it was affecting his independence in day-to-day life. And it was distressing and frustrating for his wife as well, who found it quite disruptive. And so for him, one of the tools we used was a calendar, which we felt would give him a little bit more ownership and access to the information about what was happening in his day and in his week. And we thought really carefully about the placement of that calendar. Wes tends to spend a lot of time around the kitchen, and so we found one that we could place on the fridge and removed the magnets and things around it so that it was really clear and out of distraction. And Wes also was a person that had really liked dogs throughout his lifetime. So we found a calendar that had the theme of dogs, and each month there was a different breed of dog. And so the prompt for him from his wife, whenever he asked one of these questions around what's happening today or what's happening this week, or what are we doing on Monday, she would say, ask the dogs. And so that was a little prompt for Wes to go and consult the calendar. And it didn't completely remove the questioning, but it did reduce it, and it gave him a little bit more ownership, just with that simple memory aid. Now, another compensatory strategy can be a memory book. Some people have heard about these but don't quite know what they look like. These are just some examples to show you. It can be as simple as a section about me with some key features to help orient the person, to help remind them of specific bits of information, particularly where there has been a change in where they are, if they're in a hospital, if they've been admitted for a particular acute cause, reminding them what's happened, where they are and why they're there. We can also use external aids around what I did today. This can be really helpful for that sense of achievement, for being able to have that conversation towards the end of the day around, what did you get up to? And for the person to be able to meaningfully contribute, without the difficulty of remembering themselves what the day involved. It can also be a nice way to schedule activities. And I'll just mention with activity scheduling, we always want to focus on a balance of activities that relate to achievement, and then a balance of activities that give us pleasure as well. Just moving on, we can also use environmental cues or adaptations. So these are things like signage, personal memorabilia, color coding, using contrast and lighting. And here we're trying to address oftentimes things that have affected sensory abilities, so vision or hearing or our sense of space, and remove things that might be hazards. For example, if a person is at a greater risk of falling, we might think about decluttering the furniture in the living room and increasing the light so that they have a clearer pathway to get to the kitchen. It's a really simple example. Another example, I worked with somebody called Tom, whose wife went out to meet with friends every Wednesday, and that was a really important time for her. But she was finding that when she got home, Tom hadn't eaten anything. And we, over a period, worked out that Tom was not eating because he found the kitchen just too overwhelming. He didn't quite know where to find things. He couldn't recall the steps of what he needed to do. And so for him, we created something like the picture that I've got at the bottom of the screen. We created a lunch corner in the kitchen, and it had only the things that he needed to prepare a sandwich for himself and nothing that he didn't. And so we removed the clutter, the distraction. We had all the tools at the ready. We also put a little chart on the wall, which pictorially showed the steps that he needed to use to make a simple sandwich of Vegemite. If you're Australian, you might enjoy that, and tomato. And that was sufficient to give his wife the peace of mind that she needed to be able to go out and meet with her friends for that weekly outing, and also for Tom to have some level of independence and achievement as well in making his own meal. Okay, I'll just move forward so we do have enough time for questions as well. Just a couple of slides to go. We can also use strategies. I think it's important to mention that, you know, there's such a focus on memory, but strategies can also target other areas of functioning. And so I'll illustrate this with an example. I worked with a couple called Bill and Jane, Bill being the caregiver and Jane being the person living with dementia, and they always did their shopping together. Now, Bill was getting most of the items and Jane was sort of walking beside him. But they had a system which was really lovely where Jane would, you know, take ownership of 2 to 3 items and she would have her own list. And that was really important for her to maintain. But she was starting to have trouble finding them. And you can see in the picture that I've got on the left there, going to the supermarket can sometimes be a really overwhelming experience, and it can be difficult visually and from an information processing perspective to actually find that item that we want. So we developed some strategies where Bill would actually walk with Jane to the salad dressing section, and he would talk her through and coach her through some strategies around how to select that item that was on the list. And that included things like slowing down, really developing a focused approach to visual scanning, where you are selecting what is in your field of focus and really trying to ignore or drown out what's around it, and a very systematic and methodical approach as well to scanning those shelves. So it's just an example, I think, a practical example of how some of these strategies can help with these day-to-day tasks. We can finally also use things like problem solving, which essentially just introduces a structured approach. So we might not utilize this the model in this format with the person that we're working with, but we might talk them through some steps around, you know, a structured approach to undertaking a task or solving a problem. So stating what the goal is, planning ahead how you're going to tackle it, implementing that plan, and then evaluating has it worked. It's just that structured approach that we could look at as a technique as well. Okay, just to finish off very quickly, these are some of the considerations that we think are particularly important, especially for health professionals who are thinking of utilising or implementing a cognitively focused intervention. We need to think about some of the learning principles. So it's very important to adapt whatever task or technique or material we're using to suit that particular person's level of ability, their need, their cognitive strengths and weaknesses. And that has, I think, so many important connotations towards engagement, which I'll talk about in a moment as well. We want to avoid overwhelm. Our brains can't work when they're overwhelmed. So if we're trying to teach new strategies, if we're overwhelming the person, that's not going to work. We talk about effortful processing, which doesn't mean making things hard. Rather, it means hands-on learning, involving the person and having their brains become engaged in that process. So the example I gave of semantic association, we're asking the person themselves to try and come up with those categories to link the items so that their brains are engaged in the process. And we can also think about techniques like errorless learning, where we're avoiding guessing, we're correcting mistakes as soon as they happen so that encoding and retrieval is optimized and is accurate. And spaced retrieval, where we master techniques or tasks and then gradually we increase the amount of time where we're testing that memory to try and space out the retrieval process. Also very important to think about things that affect engagement. So cognitive factors, if somebody's attention is affected, are they going to be able to attend to the full session? Do you need shorter sessions? Do they have insight into their cognitive difficulties or the impact of their cognitive difficulties? We also know that a person who is motivated and whose beliefs are aligned with the processes and the techniques is more likely to have success. And we need to think about medical, environmental, lifestyle factors. So does this person have difficulties with depression and anxiety that might be affecting their motivation? Do they live far away from opportunities for therapy, and is that going to affect their access, for example? And finishing off, we really need to think about involving our caregivers as care partners very meaningfully so that they can make direct contributions to the intervention. And often that's around assisting with finding areas of functional impact. It can be around helping with implementing and adhering to strategies outside of the intervention session. But of course, we do need as clinicians to balance this with making sure that the person living with dementia is always at the centre of our approach to care as well. And so some of the questions I encourage you to ask would be, what are the functional impact of the cognitive difficulties? To really think about the person's goals, long-term, short-term, who has set them? Are there measurable outcomes that we can look at? What kind of techniques might address those goals? And is there an evidence base for those techniques in the group? How can we engage the person with dementia and also people around them for support? We need to consider the stage of illness that they're at, the other comorbidities that they might be dealing with, what is the priority and whether they're engaged in other interventions, particularly from that perspective of overwhelm. And we need to think about their access to the intervention, whether they have the time and you have the time and resources and scope to provide that. And as clinicians as well, I think we need to think about skills and competencies and how we can access those to upskill in providing these interventions as well. So just to finish off and so that we can lead into some questions, I'd also like to acknowledge the team that I work with, the Healthy Brain Aging Program at the Brain and Mind Centre here at the University of Sydney. Of course, our staff, clinicians, researchers and students, but I really think most importantly, the participants and the patients that we work with who give us these insights. So with that, I will hand back over to Kate, and thank you for your attention.